Hello and welcome everyone. My name is Simran Chowdhury and it is my pleasure to welcome you all to today's virtual session, Navigating Migraine with Experts, Not Assumption, Turning Awareness into Better Outcomes, an awareness initiative by Voice of Healthcare and powered by Amneal Healthcare. So, migraine is far more than just a headache. We all know about this. It is one of world's most common neurological disorder and a leading cause of disability among people of all ages. Yet, despite affecting millions of individuals in India, it continues to be misunderstood, underdiagnosed, and often dismissed. So many people continue to self medicate, ignore early symptoms, or accept migraine as normal part of life. And they delay appropriate diagnosis and treatment pathways. So, through today's discussion, we hope to replace myths with medical evidence, encourage timely specialist consultation, and empower patients with the knowledge they need to take control of their health. And today, for this session, we are privileged to be joined by an exceptional panel of neurologists who have dedicated their careers to advancing migraine care, improving patient outcomes, and bringing greater awareness to neurological health. It is my pleasure to introduce our esteemed panelist for this evening, Dr. Debashish Chowdhury, Vice Chairman and Academic Head, Neurology at BLK-Max Center of Neurosciences, New Delhi. Welcome to our show, sir, and thank you so much for
Thank
joining.
you.
Thank you, sir. Dr. Shyam K. Jaiswal, Senior Consultant Neurologist at KIMS Sunshine Hospital, Hyderabad. Thank you so much for joining, sir.
Thank you.
Dr. Mukul Varma, Senior Consultant Neurologist at Indraprastha Apollo Hospital, New Delhi. Thank you so much for joining, sir. It's an honor to have you.
Thank you.
Thank you, sir. Dr. Satish Barki, Senior Advisor, Medicine and Neurologist at Command Hospital, Pune. Thank you so much for joining, sir. Dr. Vikram Sharma, Clinical Director, Neurosciences at Omega Hospital, Hyderabad, will be joining us shortly. And to begin our conversation on migraine understanding and understanding the treatment pathways, I would like to ask my first question to Dr. Debashish. So, we know that despite being one of the leading causes of disability globally, migraine continues to be widely misunderstood. If we have to understand that how serious is the true clinical and societal burden of migraine today in our country.
Right. So, actually, that we talk about migraine, we talk about the headache disorders, which are pretty common, and they are actually occurring in a spectrum from a very mild variety to a very severe variety. But unfortunately, in India, for a long time, we did not have a good data to know that what is the actual prevalence. कितना होता है माइग्रेन हमारे देश में. So lately, what has happened that under the WHO Global Burden of Disease Studies and lifting the global burden of headache disorders, two important studies have been done from India. One from Karnataka state, that is at Nimhans, and one by us from Delhi NCR region. So surprisingly, we have found that the 1 year prevalence, मतलब एक साल में कितने माइग्रेन से पीड़ित लोग होंगे इंडिया में, तो उसका एक आंकड़ा मिला है which can be considered as a rough estimate, but it is still very high. It is about 25%. And in an earlier study from the eastern India, there was a study by Ray et al. They have estimated to be about 14%. So somewhere in between, I think the India is having this great burden of migraine patients. And actually, in terms of total numbers, absolute numbers, if you see, it will be about more than 200 million people, right? About 211 to 213 million people will be suffering from migraine in India at one particular time epoch, that is 1 year prevalence. Now, we just published another important paper in the International Journal of Headache and Pain, that if you ask that how many people will have a headache tomorrow, can we have an estimate of that? Based on the data of 15 countries in the world, including India, we have found that about 600 million people will have headaches tomorrow, which you can imagine is a staggering number. And out of that, 50% would be having migraine. So it's a very common disease. There is a great burden. And as you rightly said, the global burden of disease studies has established कि migraine सबसे ज़्यादा disabling number 2 disease है. सबसे पहले है बैक पेन, लोअर बैक पेन, एंड उसके बाद ही माइग्रेन है. और अगर यंग पॉपुलेशन और फीमेल्स को देखेंगे तो इट इज नंबर 1 in terms of its prevalence as well as in terms of the disability that is it's causing. So there is a great burden, we need to understand that, and it is not to be trivialized as just a simple headache.
Very well pointed out, sir, and that how it is creating disability and how many people are affected, and yet we ignore it. People ignore it. They do not take their symptoms seriously. They do not go to consultation. They do not go to the right doctor for this. And I think that's what we are lacking. And more than that, I believe there's so many misinformation, myths around this. So I think that is also something which we need to clear the air around it. So I would like to ask my next question, Dr. Sham. So, building on what Dr. Debashish has said, and if you could tell us about the most persistent myths surrounding the migraine that continue to impact timely diagnosis and evidence based treatment, what are those, sir?
Yeah, as just sir rightly said about the prevalence and how the we have the misdiagnosis. So we what we see commonly in our practice that there is definitely low awareness among the public. They say it's just headache. They don't. There's a delayed reaching to the healthcare seeking. That seeking attitude is not there. They reach late to the say just a normal headache and they go to over the counter drugs and take the medications. The under recognizing in the primary cares, the because the headache usually they don't reach to the neurologist for they reach to the physicians or RMP and they say it's just a normal headache. Many times generally is misdiagnosis on the primary cares and even on the level of the super specialist. They say just kind of sinus headache or tension type headache and many times is the limited access also the headache specialist. Now the lots of headache specialists coming in our country and then they definitely they have the access to the headache specialist but definitely limited access and definitely sometimes the economic barrier they see reaching out to the consultant it's not important and we can just get 1 2 rupees crossing combi flam and the things will be there. So these are the things where we see that still the prevalence what sees 14-20% and it could be more if we have the when the patient reaching to the headache specialist and the neurologist and the different lifestyle changes that now the urban lifestyles whatever is we see that urban lifestyles and in the because in Hyderabad I see this kind of IT hub areas and these lifestyle changes the this also having the lots of trigger factors which may be some unidentified. We'll discuss that also in the later questions which are causing the more prevalence and maybe it be more than the 14-20%. So these are my take on these questions. Yes, yeah.
Thank you, sir. Thank you so much for answering that question. And it is rightly said that most of the time it is not diagnosed on time, and because of that, we delay the treatment as well. I would like to ask questions to Dr. Mukul. So, from an early recognition perspective, what symptoms or patient's pattern should clinician and primary care providers must be vigilant about when it comes to migraine in our country?
Thank you. That's a very good question. Actually, migraine is a primary headache syndrome. So there are two kinds of headache syndromes broadly classified: primary headache and secondary headache. Primary headache is a headache which is a entity in its own right. It's not because of some other illness. So migraine is a primary headache. But many times people come to us with some other underlying cause for the headache, and it might not be migraine. So it's very important for us to be very vigilant for certain things which we have to look out for, which will give clues that this patient may be actually having a secondary headache. Maybe something more sinister is, lurking. And so we have to investigate these patients. So there are some things which we look for. For example, if we call these the warning signs of secondary headache. So if the history is very short, if it's not a very long history, if the patient has had headache only for the last say a month or two, then that is a warning sign. And if the onset is after the age of 50, the headache has started only after the age of 50, that's a warning sign. If the person has some other systemic illness like tuberculosis or some other illness which might be HIV, cancer, so we have to investigate further. If there is fever, weight loss, if there is a change in the headache pattern, for example, he's having headache, but now the headaches have become far more frequent, more severe, more prolonged. And if there is a headache which changes with posture, for example, if he lies down, his headache increases, or if he sits, his headache increases or decreases. If there is a headache related to straining or exertion or coughing, so these things are warning signs which we have to be very vigilant about. If the headache is, we call something a thunderclap headache, which means that it comes like a bolt from the blue. Sudden headache which reaches its maximum severity within seconds. So all these things, these patient or the patient has any neurological signs. If you examine him and if he has some neurological signs, because in migraine there are no signs. If he has something we call papilledema, disc edema, we look at the fundus of the eye and we see that there's a edema. And so all these things warrant investigation for secondary causes of headache, because it's very important not to miss out any of these things. And so this is what I wanted to kind of convey.
Thank you, sir. Thank you so much for highlighting these signs and symptoms very clearly. That what are things leads to migraine and how do we identify it, and what triggers the most as well. My next question is Dr. Satish. So many individuals continue to rely on the over-the-counter medication and delay specialist consultation because they always ignore, okay, this is just a headache. I can take a pill and then that next day, next morning, I'll be okay. So if you have to explain us that what systematic and behavioral factors are contributing to late presentation in migraine care.
Yeah, migraine seems to be like everyone is so much trivializing these headaches. Actually, lots of multiple factors, both behavioral, patient-related factors, and healthcare-related barriers, social-demographic factors. Multiple factors will play in sync, where people will reach to doctors late, and even if they reach, the treatment or the diagnosis is also delayed. Behavioral factors where you, as you yourself said, everyone feels that headache is just part of the life. Okay, they don't pay much attention to it, so they rely on over the counter medications, have symptom relief, they feel okay, it's okay with them, and they just continue that. So there's lack of knowledge about migraine and its related symptoms and what are the treatments available. There is also some social stigma which is associated with a few people, where they feel it is psychological, where it is familial, so they don't want to come out for treatment. There's lots of fear and misconception also related to the migraine treatment, its side effects, treatment dependency, and lots of people have melanoma because most of the people are young, and in the productive age group, they have the priorities for work, responsibilities towards the families, and lots of people where there is migraine is atypical, where they don't have headaches as such, but they have aura, GI symptoms, atypical migraineurs. They don't know it is actually a migraine. And when it comes to healthcare related barriers, where there is poor primary healthcare recognition of these symptoms and diagnosis, there is limited awareness among the healthcare providers themselves, where they underdiagnose or delay the referrals because they feel it is some sort of a stress related headache, some sinus headache, and there is a lack of neurologists and headache specialists, as Jaiswal sir brought out this thing. So there's long waiting, the costs which are involved in investigations or the treatment. So all these, and then the limited public health awareness. And to increase this, there's always this low socioeconomic status, illiteracy, rural background, and some other factors which all in all make it difficult for everyone. So there is late presentation, and then because of which there is late diagnosis, there is the quality of life is affected, and the severity is affected. They become more severe. They become transformed from episodic migraine to chronic migraine. So these are few of them which definitely making a diagnosis of treatment and treatment of migraine late.
Very rightly pointed out. So I think there's not one factor which contributes to this. There are many factors which contributes to the late presentation of migraine care and late presentation of migraine to the specialist. As there's some behavioral aspect, the ignorance aspect, and the education and awareness aspect as well. So now we have understood the migraine, what exactly it is, and continues to evolve. So, to do the treatment options are available today. So now going ahead and looking at the scientific advances that are changing the migraine management, I would like to ask my question, Dr. Debashish. So, our understanding of migraine has evolved significantly from a vascular disorder to a complex neurological disease. So, what major scientific advances have shaped the current migraine management today?
Right. So I think before we go there, I think it is very important to know that what is migraine, because Dr. Mukul has tried to segregate migraine primary headaches from the secondary headache and talked about the red flags that would suggest that there is a secondary headache. But if you see a common person suffering from headache, out of 10 people, about 8 or 9 will have a primary headache, and among them, about 8 will be having migraine. So, what is migraine? Migraine is it's a primary headache disorder. That means that there is no pathology, either structural or otherwise, that is discernible on various investigations that you do either by clinical examination or by investigation to suggest the genesis of that headache. So it is characterized by a longer duration, which we usually tell about 4 से 72 घंटे तक रहते हैं, 4 to 72 hours. It is usually unilateral, hemicranial, but it can be holocranial, that is involving both sides of the headache. It is throbbing quality or the pulsatile quality, right? It is associated with nausea, vomiting, and other systemic features like intense aversion to light, which we call as a photophobia, intense aversion to sound, which is called as a phonophobia, and some people have intense aversion to smell, which is we call as a osmophobia, right?
Okay.
And most importantly, that during these attacks, the patients, they cannot function normally. So either they retire in a room which is quiet, dark, and many a times they induce vomiting to get a relief, right? So they become vegetative. It severely restricts their activity at that particular time when they are in the attack. And there is no biological test which will suggest the diagnosis of migraine. इसीलिए इतना मिसकंसेप्शन है, लोगों को पता ही नहीं है. लोग सोचते हैं कि एमआरआई करा लेंगे, सीटी स्कैन करा लेंगे, ब्लड टेस्ट करा लेंगे तो माइग्रेन पता लगेगा. नहीं, माइग्रेन इज डायग्नोज्ड बाय अ सेट ऑफ क्राइटेरिया, क्लिनिकल क्राइटेरिया. और ये सब जब हमको पता लगता है तब हमको ये मालूम होना चाहिए कि ये क्यों हो रहा है, why this is happening. So migraine happens in a susceptible hyper excitable brain. माइग्रेन पेशेंट्स के ब्रेन एक हाइपर एक्साइटेबल स्टेट में रहते हैं. क्यों रहते हैं? क्योंकि ये जेनेटिकली ड्रिवन है. मोस्टली अबाउट 60 to 70% ऑफ माइग्रेन पेशेंट्स will have either father, mother, brother, sister, grandfather, grandmother suffering from the disease which might not have been qualified or quantified or diagnosed previously, right? Now this hyper excitable brain, यानी कि ब्रेन में जो उत्तेजना, जो केमिकल्स उत्तेजना होती है, उससे क्या होता है? उससे ये होता है कि जो छोटे छोटे ट्रिगर्स होते हैं, जैसे आप धूप में बाहर गए, शॉपिंग करने गए, ट्रैवल कर लिया, खाना नहीं खाया, नींद पूरी नहीं आई, स्ट्रेस हो गया, फीमेल्स में मेंस्ट्रुअल साइकिल के शुरुआत वाले दिन, ये सभी छोटे छोटे ट्रिगर्स जो हैं इस हाइपर एक्साइटेबल ब्रेन में एक जगह है हाइपोथैलेमस, उसको अफेक्ट करता है. और जैसे ही ये हाइपोथैलेमिक एक्टिवेशन होता है तो हम हाइपोथैलेमस ब्रेन में बैलेंस करता है बिकॉज ऑफ ऑटोनॉमिक नर्वस सिस्टम कंट्रोल. एक को कहते हैं सिंपैथेटिक और एक को कहते हैं पैरासिम्पैथेटिक. इस दोनों में हमारा बैलेंस चलता है, तो वो गड़बड़ा जाता है. और उसके वजह से जो ब्लड वेसल्स हैं, जो ब्रेन के जो सरफेस में जो ड्यूरा है जो कि ब्रेन को सप्लाई कर रही है, उसमें ये ब्लड सप्लाई में परिवर्तन आता है। और ये परिवर्तन आने के वजह से कुछ न्यूरोट्रांसमीटर्स निकलते हैं, जिसमें अभी जो शोध कार्य हुआ है उसे ये पता लगता है कि इसमें अधिकांश जो न्यूरोट्रांसमीटर्स हैं वो पेन सेंसिटिव स्ट्रक्चर्स को इफेक्ट करते हैं। और उसमें एक प्रमुख न्यूरोट्रांसमीटर है, उसको हम कहते हैं CGRP, कैल्सिटोनिन जीन रिलेटेड पेप्टाइड। और इसके साथ साथ एक और भी है, पिट्यूटरी एडेनिलेट साइक्लेज पेप्टाइड। ये और भी काफी सारे हैं, लेकिन ये दो सबसे इंपॉर्टेंट माना जाता है, जो कि ये पेन पाथवे को एक्टिवेट करता है। और ब्रेन में पेन पाथवे एक्टिवेट होने की वजह से पेशेंट को कॉन्शियस परसेप्शन ऑफ पेन होता है। लेकिन मैं ये बताना चाहूंगा कि माइग्रेन इज नॉट ए हेडेक डिसऑर्डर। हेडेक इज जस्ट द फ्रंट फेस ऑफ दैट।
Yes.
माइग्रेन इज अ डिसऑर्डर ऑफ सेंसरी डिसमॉड्यूलेशन। हमारा जो सेंसरी सिस्टम है ब्रेन का, वो बिकॉज ऑफ दिस हाइपर एक्साइटेबल स्टेट डिसमॉड्यूलेटेड स्टेट में रहता है, यानी कि संपूर्ण नॉर्मल हिसाब से काम नहीं कर पाता है। और इसके वजह से जो पेन के नेटवर्क्स हैं वो नेटवर्क्स में खराबी आ जाती है, और ये सारे ट्रिगर्ड होते हैं वेरियस मैकेनिज्म, समटाइम्स नोन एंड समटाइम्स अननोन। और इसके वजह से बार बार ये हेडेक्स होने की संभावना बनती है। तो माइग्रेन को ये समझना पड़ेगा कि ये एक ब्रेन डिजीज है, ये क्रॉनिक न्यूरोलॉजिकल डिजीज है, और हेडेक इसका एक स्मॉल हिस्सा है। हेडेक हालांकि सबसे प्रोमिनेंट है, लेकिन इसके साथ साथ नौशिया, वॉमिटिंग, लाइट से प्रॉब्लम, साउंड से प्रॉब्लम, वर्टाइगो, चक्कर आना, बॉडी में पेन होना, कुछ पेशेंट्स में जैसे डॉक्टर मुकुल ने बताया ऑरा हो सकता है, यानी कि ट्रांजिएंट विजुअल न्यूरोलॉजिकल डिस्फंक्शन हो सकता है। तो ये सारी चीज माइग्रेन के साथ जुड़े हैं, और बच्चों में काफी अलग अलग तरह के सिस्टम्स में माइग्रेन मैनिफेस्ट कर सकता है। जैसे गर्दन में टेढ़ापन आ जाना, जिसको टॉर्टिकोलिस कहते हैं। पेन एब्डोमेन होना, जैसे पेट में अचानक दर्द हो रहा है, उसको हेडेक नहीं हो रहा है, लेकिन पेट में दर्द हो रहा है। तो इसीलिए माइग्रेन का जब हम बात करते हैं कि क्या शोध कार्य हुआ है, पिछले 2 दशकों में ये सामने आया है कि ये जो मॉलिक्यूल निकलते हैं CGRP और पैकैप, इसको टारगेट करके हम थेरेपी को आगे बढ़ा सकते हैं। और इसके इंडीड ये रिसर्च के बाद ऐसे बहुत सारे दवाइयां अब हमारे पास उपलब्ध हैं जो कि माइग्रेन को अच्छी तरह अटैक कर सकते हैं सॉरी, और इसको ठीक कर सकते हैं। माइग्रेन क्योंकि जेनेटिकली ड्रिवन है, क्रॉनिक न्यूरोलॉजिकल डिसऑर्डर है, ये जाएगा नहीं कंप्लीटली, इसको जड़ से उखाड़ डालना संभव नहीं है। हम क्या कर सकते हैं, दवाई से, सही इलाज से इसको कंट्रोल में ला सकते हैं, जबकि अटैक फ्रीक्वेंसी और सिवियरिटी काफी कम हो जाए, और जिससे पेशेंट का नॉर्मल जीवन चलता रहे, क्वालिटी ऑफ लाइफ रिमेन्स ओके, and that is the aim of the entire migraine treatment. And these are the developments which has happened. We now are able to identify that what are the pain networks that are affected in migraine. We are also able to measure these neurotransmitters either in the venous sample or in the jugular venous sample, and we are also able to quantitate the difficulties that the patient is having by noting their headache burden, by noting their triggers, and therefore a comprehensive treatment plan is possible for migraine patients provided they go to the right person. अब एक चीज और भी बता दूं इसमें कि माइग्रेन हेडेक जब होता है तब क्या रहता है, अक्सर ये रहता है कि चलो सबसे पहले आई डॉक्टर के पास जाए, आई का चेक कराए कि नंबर तो नहीं बढ़ गया, नंबर तो नहीं आ गया। उसके बाद माइग्रेन में बैक में पेन होता है, नेक के पीछे पेन होता है, तो चलो ऑर्थोपेडिशियन के साथ जाते हैं। एक कॉमन बोलते हैं कि मेरे को सर्वाइकल हो गया। काफी माइग्रेन पेशेंट्स को वॉमिटिंग, नौशिया और खाना पचता नहीं है, गैस्ट्रिक एम्प्टिंग डिले होता है, तो गैस्ट्रोएंटरोलॉजिस्ट के पास जाता है कि कहीं देखिए मेरा गैस का प्रॉब्लम तो नहीं हो रहा है। काफी मरीज को जिनको मेंस्ट्रुअल माइग्रेन है, जिनको मेंस्ट्रुअल टाइम आने के समय, पीरियड आने के समय माइग्रेन होता है, वो गायनेकोलॉजिस्ट के पास जाते हैं, कहीं प्री में मेंस्ट्रुअल सिम्टम्स तो नहीं है। तो इसीलिए माइग्रेन, पहले माइग्रेन के जो लगातार होने वाले जो पेशेंट्स होते हैं वो काफी जगह भटकते रहते हैं, और जैसे बताया, साइनस इज अ वेरी कॉमन प्रॉब्लम। साइनस में आंख के आसपास दर्द होता है, चीक में दर्द होता है, नाक से पानी आ सकता है, ये सारे सिम्टम्स माइग्रेन में भी हो सकते हैं। तो ये ईएनटी डॉक्टर के पास जाते हैं और एक्सरे कराते हैं साइनस के। अगर आप 10 आम आदमी का एक्सरे कराएंगे तो उसमें 8 आदमी का साइनस में कुछ ना कुछ खराबी निकल आएगा, और उसको साइनोसाइटिस कहा जाता है। और जब साइनोसाइटिस का ट्रीटमेंट के बाद भी मरीज ठीक नहीं होता तो घूम फिर के मरीज फिर न्यूरोलॉजिस्ट के पास या हेडेक स्पेशलिस्ट के पास आता है। तब तक उसका हेडेक जो एपिसोडिक था, जो बीच बीच में हो रहा था, महीने में 1 बार, 2 बार, 5 बार, वो अब बढ़ के 15 बार या 20 बार होने को लगता है। और उसमें पर्सन क्या करता है, वो गोलियां खाता है, और गोलियां खाते वक्त उसने उस और एक हेडेक की उत्पत्ति होती है जो कि कहते हैं मेडिकेशन ओवरयूज हेडेक। तो बड़ा कॉम्प्लेक्स सिचुएशन हो जाता है और हम सभी को इन सब पेशेंट्स को ट्रीट करना एक चैलेंजिंग टास्क बन जाता है। इसीलिए मैं सबसे अनुरोध करूंगा कि जब भी आपको रिकरेंट हेडेक्स हो रहा है, बार बार हेडेक्स हो रहा है, तो एटलीस्ट आप एक इनिशियल कंसल्टेशन कीजिए एक फिजिशियन के साथ या न्यूरोलॉजिस्ट के साथ, कहीं ये माइग्रेन तो नहीं है। अगर माइग्रेन है तो उसका सटीक इलाज उपलब्ध है।
And I think, sir, it becomes very important to rule out in start only that this is not migraine. जैसे कि आपने बताया कि हम लोगों को जब सर दर्द होता है तो हम कितने कितने डिफरेंट चीज़ों को सोच के और अलग अलग डॉक्टर्स के पास भागते हैं, बट एट वेरी एंड लास्ट स्टेज पे वी थिंक दैट इट कुड बी समथिंग एल्स, तब हम जाके न्यूरोलॉजिस्ट के पास आते हैं। एंड आई थिंक इफ वी कैन सस्पेक्ट इट कि हम पहले एक बार न्यूरोलॉजिस्ट के पास चले जाएं, देन वी कैन फिगर इट आउट एंड flag it out कि if this is
Right.
migraine or not. So I think
Absolutely.
that would be a better way to do it. और जिस तरीके से आपने हमें समझाया कि कैसे थेरेपीज लाइक CGRP टारगेटेड थेरेपीज हैं, जो एक ब्रेक थ्रू है जहाँ पे वी कैन इट इज एक्टिंग एज अ प्रिवेंटिव केयर स्ट्रेटजीज फॉर द पेशेंट आउटकम्स ऑल्सो. So I think these are the advancements and innovations which are helping the patients and as well as the clinicians to work together into this direction. Thank you so much, sir. You explained us very clearly and very, in depth that how we have to look to migraine and how we, have to treat it. So thank you so much for this. Moving to my next question, Dr. Shyam. So as sir has already explained us about few of the therapies which are available, but I guess in today's time, everything is incomplete if we do not talk about precision medicine. So, precision-driven migraine management today is particularly in a tailoring therapies, which is based on patient's phenotype, triggerings, and disease pattern. So, how feasible are these therapies if we talk about precision-driven migraine management?
Yes. So in the era of AI, everyone has the access to the AI, and we need to be precision based definitely because as Debashish sir explained that we have different kind of migraine phenotypes. Like some are without aura, chronic migraine, menstrual migraine, some are vestibular with neck pain, other things. And again, it depends on the different disease burden and pattern. Also, they have how much monthly headache is there, what is the disability. They are definitely some patients, as I said, is having some medication overuse headache also. So different tailoring on the based of triggers is very important. As I said that there's a lack of sleeps, some hormonal changes, weather changes, different kind of stress, different kind of foods, alcohol, smoking, caffeine. All these are triggers. We have to understand all those triggers, and definitely with the headache management with the precision medicines, we need to explain all those triggers and how to avoid the triggers. As we know that patients have many comorbidities also, and suppose some patients have the blood pressure with the migraine, so in that cases definitely beta blockers will help. Some patients have chronic migraine, they have kind of anxiety and depressions, and then we have to use some kind of medications like valproate and topiramate, which will help for other things also. Some people have obese also. We see many migraine patients or obesity, and obesity is also one of the kind of associated features for the migraine. In that patients, we have to trailing with the kind of topiramate. Some people are underweight and they have insomnia, then we have to use the kind of some kind of SNRI or TCs. And again, some patients are planning for the pregnancy. We see that during the perimenstrual period and then the peri-pregnancy, we see the headache. So we have to tailor the medication accordingly. And different, we have to understand that based on the patient, have some patient have nausea, vomitings, or the prior response was there, what is the side effect profile. And as certain now CGRP targeted therapy is very there is a things We are now looking for the major advance come, and the medications are available in India. I mean, these are monoclonal antibodies for preventions. Now we have the oral GPENT also, that's called oral CGRP receptor antagonist, which help for the particular kind of patients. We are medication overuse headache, like some are triptan failures also, and different kinds of biomarkers now coming. The research is going on. Some definitely the strong genetic component also there. We see the many patients are hereditary. The parents are having the migraine, and they also having the children's also having the headache. So these are things where we are kind of modern individualized managements are possible when we have the detailed headache phenotypes. Now we have the electronic diary. We can understand the trigger pattern analysis. We can assess their sleep, stress, hormone, lifestyles, the different comorbid conditions like depression, anxiety, hypertension, obesity, the epilepsy on some patients. What was the previous medication response, or the NSAID with the triptans, and what are the patient goals? They just want rapid relief. They want fewer attacks. They want fewer side effects. They are planning for pregnancy, and selection of the targeted preventive therapy when appropriate. We can do. Now we have the some kind of REN device also available with us in India. These are regular assessments and treatment adjustments. We can definitely reach to the precision tailored medication to the patients. We have some limitation, like definitely as sir said, there's no reliable test which predicts which medication will work, which will not work. Many treatment decisions are there which involve the trial and errors, and access to near therapies varies, because of the different economic barriers are there. Now we have these facilities available in the kind of major cities, and these are definitely migraines kind of biologically heterogeneous. These are, meaning patients with similar symptoms may have different underlying mechanism. So definitely it is feasible, but we need to be understood, as sir said, these are patients reaching to the primary physician first, and rarely reaching the very late part they reach to the neurologist. And many neurologists also, they're now understanding that we have the kind of different kind of available facilities for the treating headache. Definitely it's possible, but we need the lots of we have to go. It's a very long way to go to treat precision medicines. Yeah, thank you.
Very rightly mentioned. So there's a long way to go for treating migraine patients, and with such new therapies, the precision-driven management, I think there's a long way. And like you also mentioned a point for electronic management and things like that, because now we use a lot of variables. We can definitely track our lifestyle, our routine, whether it is triggered through sleep or it is triggered to anything else. So I think that recording of all those things can definitely help us to track what is exactly triggering and how we can manage it. As we are talking about the treatment management and things like that, I would like to ask my question, Dr. Mukul. So, Dr. Shyam also mentioned about biomarkers. So, what role can biomarkers, neuroimaging, and digital health technologies play in enabling more accurate diagnosis and long-term treatment monitoring if we have to, actually study a case and do all such things?
So, like Dr. Devashish has already mentioned and enumerated, that this is a diagnosis which is made by taking a detailed history from the patient. Biomarkers, there are no biomarkers in clinical practice which will help us diagnose this patient. They are all in research, and out of that research we have brought out CGRP, which Dr. Devashish has already mentioned. This calcitonin gene related peptide has been found to be a major culprit in the headache, that is because of migraine. And now we have targeted therapies against CGRP. And so there is no biomarker in clinical practice, and there is no need to do any biomarker study as far as today is concerned. The other thing is about neuroimaging. There is no role of neuroimaging in migraine diagnosis. In fact, it is done to rule out other causes of headache, not to not to see something abnormal in migraine patients. In migraine patients, the MRI looks normal, and therefore, when, like I told you initially, if there are certain red flags where we feel that this patient may be harboring some other illness, then we go for these neuroimaging. Otherwise, there is no need. If the patient has a proper history which suggests that he has migraine, there's really no need. The As far as the digital, you asked about digital, health technologies. So I think the role of digital health technology here would be for a person to be able to maintain a headache diary, because that will tell him how many headaches he's having in a month, which will be easily transferred to his doctor, and the doctor can then understand whether the treatment that he has been prescribed is actually helping him or not. And like you said, that they can also kind of find out whether their sleep was not good enough, maybe that triggered it. But otherwise, really, it's quite a simple situation where a good history. So at least if you spend half an hour with the patient, I think 25 minutes have to be spent in taking history of the patient, and that will tell you what he's suffering from, that it is migraine. Now, having said that, if somebody comes with not very frequent headaches, then we use abortive treatment. We abort the headache whenever the headache occurs, and we there are several things which we can use, like non-steroidal anti-inflammatory, triptans. All these things are available. But if the patient comes with frequent headaches, so then he needs preventive therapy. And if the headaches are being treated very frequently with abortive therapies, like Dr. Devashish has already enumerated, then he develops this situation called medication overuse headache, and which increases his headache even more. It makes it even more frequent. So preventives are the mainstay of treating migraines, which are happening on a frequent basis. Up till now, our preventives were non-specific. We were using medicines which were being used to treat other medical conditions like epilepsy, depression, hypertension, and we were using these medicines because we had seen that these medicines help to prevent migraine as well. But because they were not targeted for migraine, they were causing a lot of side effects. And that's why, with the advent of the CGRP antagonists, like the monoclonal antibodies, which are given as an injection once a month, or the oral anti-CGRP receptor medication, these are targeted, and therefore their side effects are almost negligible. That's why they are creating a lot of excitement in the treatment and prevention of migraine, because that is very important.
Yes, I think you have rightly mentioned about all such things where we can take this ahead. And like you specifically mentioned about the neuroimaging, that it is not exactly for the diagnosis of migraine. It is I think that this is not relevant in case of when we're talking about migraine for the diagnosis aspect. So thank you so much for clearing that misconception about this. As we move ahead, my next question is Dr. Satish. So, beyond pharmacological therapies, which lifestyle, behavioral, or integrative interventions currently have the strongest evidence in improving the migraine outcomes?
Yeah. Current guidelines always recommend that we combine both pharmacological and non-pharmacological interventions to treat. As Mukul sir brought up, most of these drugs have side effects. None of the non-pharmacological interventions do have any side effects. So that's the best part of it. Personally, I always tell my patients that if you do not undergo these behavioral or lifestyle modifications, then none of the medications are going to work. That is for sure. Only medications, that is only treatment, the tablets or injections would definitely not help, because this is a lifestyle disease. So we have a few non-pharmacological interventions which have very strong evidence in the treatment of migraine, where the frequency gets reduced, the severity comes down, the disability associated with migraine goes down, and the quality of life also improves. So few of them are lifestyle modification, cognitive behavioral therapy, biofeedback mechanism, relaxation, various relaxation techniques, regular aerobic exercises. They are all have good, strong evidence. Some other interventions which have mild to moderate evidence are sleep optimization, mindfulness based interventions, some dietary modifications, even acupuncture, and some nutraceuticals do help. So for lifestyle modification, it's the one of the strong evidences for this is for the treatment of migraine. So a mnemonic which goes by seeds, that is S for good sleep, then eat regularly, exercise regularly, and you have maintain a headache diary, that is for D, and S for stress management using any of the techniques. So you use these, and then Malana, your migraine will definitely help. Cognitive behavioral therapy is again has one of the strongest evidences among these behavioral therapies. It helps in coping the stress. It reduces migraine related disability. It decreases anxiety and depression associated with the migraine. So various biofeedback techniques help patients to control their physiological responses, such as muscle tension, skin temperature. So thermal and but usually routinely clinically these are not available. Relaxation techniques commonly used are progressive muscle relaxation, deep breathing exercises, yoga, tai chi, and they what do they do is they reduce the sympathetic overdrive and help improve the stress management and stress triggered migraines. Regular aerobic exercises like swimming, jogging, running, walking, so that helps also in helping the endorphins which are released helps in mood elevation. They give good sleep. Then what has been seen, sleep optimization means what has been seen as migraine is triggered by sleep deprivation, and it is also an effect of migraine itself. So if optimize the sleep, it also definitely helps. And there are some mindfulness techniques and all those things which possibly can help. And dietary interventions, well, then, as such, you don't require any strict, broad type of dietary restrictions. What you need to do is avoid individual diets, well, then, which could be a trigger for an individual. Again, these are very specific to the individual. He may have some people can have a trigger with alcohol, some may have with caffeine, more caffeine, some may have with less caffeine, some other. So such dietary restrictions can be used. As a comprehensive plan, what I would definitely advise my all of my patients is regular exercises at least 3 to 5 times a week, then regular sleep and regular meals. You have to identify your own triggers. Everyone has his own triggers, so identify them. Try to avoid them as much possible. Maintain a good headache diary so that decision making becomes much more scientific. Keep yourself hydrated. Stress management using relaxation techniques, yoga, and all those things. And wherever and whenever it is required, last is preventive or malana acute medication for whenever it is needed. The medicine is always last. You have to do rest everything the first to malana have good relief with the migraine.
So thank you so much. You have very well highlighted what are the lifestyle factors which contributes to this or how it can affect us. So I think a person who's suffering from or who records episodes of migraine, they must note down all these points, all these factors, if any of these things are contributing or triggering to the migraine attack. So as you just focused on and shed light on the um, behavioral aspects and let's say the lifestyle factors which contributes to this, and Dr. Mukul emphasized on some medication which might sometimes also have some side effects. I have a very relevant question from a live audience. I would like to present this, and if we can take his question and resolve his problem. So he says, I'm past epileptic patient since from age 10, and my last migraine episode was stopped at 2018. I stopped the medication without consulting the doctor due to side effects and impact in professional career growth. Currently, I'm completely fine, but if strained more physically, I will get headache. How do you see this? Dr. Mukul, if you'd like to take this, please.
Well, so when he strains, he gets headache. So he's not mentioned how many times in a month he gets headache. If it's 2 or 3 times in a month, then there is nothing to really worry. He does not have to restart any of his medication, and he needs to just take some non-steroidal anti-inflammatory agent whenever he gets his headache. Or he can try to not, I mean, to avoid the situation where he needs to strain and where he gets the headache. So if it's kind of something which is interfering with his lifestyle and causing several headaches in a month, then of course all those factors which Dr. Barki enumerated, they need to be considered. He needs to have a regular lifestyle. He needs to have proper sleep. He needs to eat on time. He needs to have plenty of liquids. He needs to do some regular exercise, and he needs to avoid those kind of situations which cause his headache. And if it cannot be avoided, then he takes some medicine. So that's what I think. If he's married, then he needs to tell his wife every morning that he loves her and he can't live without her.
I think that would help him, sir. Thank you so much, sir, for answering this question. And we also have another question from Dr. Girish. It's only that it is related to your lifestyle disorder also. I think he just want to contribute this way. And due to vagus nerve irritation at C1 and C2 level. So, thank you so much, Dr. Girish, for this input. I would like to take my next question to Dr. Debashish. So, as we discussed about the treatment options which are available, and they are empowering patients with knowledge, which is equally essential. So, moving on our discussion to build a more patient-centric future for migraine care, how can healthcare system move beyond episodic symptom relief towards more preventive and patient centric migraine care pathways in this era or the coming time which we are about to enter?
Yeah. So I think the first thing we should understand when we talk about, I think this, kind of concept of this lifestyle modification is much hyped, and actually it is improperly put into. People tend to believe that this is a lifestyle disorder. There is nothing brain functioning abnormality in this. This is all psychological. This is all mental disease, as has been prevalent idea, and therefore little bit of exercise here and there, a little bit of moving around will help. It is not so. It is primarily a brain disorder. You have to understand this. It is genetically driven. Brain is hyperexcitable. So whatever you do, you need to calm down that hyperexcitable state and make the prevention as a key pillar in your treatment plan. I see migraine treatment into 4 pillars. The first is the acute treatment. When the patient has got this acute headache attacks or an other bothersome symptom like intense nausea, intense photophobia or phonophobia, you need to abort that, right? And there are now medications. There are non-specific medications, as Dr. Mukul has said, the NSAIDs and others. Then there are triptans, and now we have got the CGRP antagonists which are available, which can actually target this acute medication. But it is not merely the availability of the medications. The point is that when do you take these acute medications? Most of the doctors who treat migraine fail to tell the patient that you have to take it early. आपको जल्दी लेना है ये, आप वेट नहीं करेंगे 2 घंटे 3 घंटे, क्योंकि अगर आप वैसा वेट करेंगे तो आपके ब्रेन में एक प्रोसेस होगा जिसको कहते हैं सेंट्रल sensitization. Pain pathways become already hyper excitable and they become more sensitized to the barrage of the sensory information that is coming to your brain, and it will not be effective. So therefore, the acute medication, whatever may be prescribed to you by a doctor, you must take it early on. The real challenge is to abort these acute attacks, because if you don't do that, and if it only just subsides and again comes back, then that causes a cycle of chronicity, and that is a recipe of chronic migraine and a medication overuse headache, because patient will again take the medication after some time because he's not getting full relief, right? So acute treatment must be done. It must be adequate. The dose must be adequate, and it should be given at the right time. That an initial within about half an hour or so of the acute attack. There are ways to identify the acute severity. Most of the migraine patients who are having chronic headaches, they tend to identify कि ये वाला headache मेरे को बहुत ज़्यादा हो रहा है, ये वाला headache मेरे को हल्का सा शुरू हुआ है. So they can actually titrate their medications accordingly. So the physician has a duty to inform the patients that what kind of medication, acute medication, he or she wants to take during that acute attack. So this is pillar one. The second pillar is, as Dr. Mukul has said, that if the attacks become more, by more, it usually means around 4, right? Conventionally, अगर 4 दिन 4 attacks हो जा रहे हैं महीने में या उससे ज़्यादा, so then the patients will need something to actually reduce that frequency to even to 1 or 2, right? But in some people, even one attack may not be permissible. Like I have got a patient, who is a pilot. Even a single attack would be devastating. I've got a patient who is a dancer, professional dancer. Before the performance, if she has a severe migraine, the entire performance goes off. So in those patients, there might be exceptions where you would like to start a preventive treatment early. There are other variants of migraine where you would like to treat the treatment even if there is a single attack. Like there is one variant of migraine in which there can be a recurrent paralysis, right? Half of the body. So in those patients, you need to start the preventive treatment early. But most of the patients, you will try to start the preventive treatment when it becomes bothersome, and that is about 4 attacks per month, right? Now, this preventive medications, you need to tell the patients, whatever you do, it will take time to be effective. It needs to be continued for some time. It is not just 1 month, 2 months, 3 months course, right? Depending on your response, we'd like to continue your treatment, and its average is on about 6 to 9 months of treatment. By that time, the brain is stabilized and you become better, and then we can attempt a withdrawal of the treatment, right? So this is number 2, is the prevention. Prevention is very important. And now with the advent of anti-CGRP drugs, especially these monoclonal antibodies, right, MAPs, which are given as injections, monthly injections subcutaneously, that has changed the entire complexion of migraine treatment. You imagine a patient taking an oral drug every day, forgetting some day, forgetting not taking some other day. But here, one single shot is going to prevent the migraine attacks occurring for entire month. So that's a great thing, and with minimal or no side effects. Of course, the cost is a consideration in India, and I think that not everybody will be able to afford it, but there will be sizable number of patients who will be able to afford that. So preventive therapy is the second pillar. Acute therapy is the first pillar. The third pillar is the trigger identification. You need to ask the patients to maintain a headache diary very diligently, and they would note that for each attack, what is the trigger. And then they can identify some of the food items, as Dr. Barki was talking about, some environmental triggers like exposure to sunlight, travel, stress. All these triggers need to be identified because many of them can be avoided or prevented so that the attack frequency comes down, right? I have a patient who invariably will get a headache when she goes out in the sun to the market. So I asked her to use an umbrella, use a cap, use a goggles, right? Or use a special lens called FL41 lens. So in that actually decreases the photophobia and decreases the headache, right? She was greatly benefited out of it. This is the third pillar. The fourth pillar is the lifestyle modification. And to make the matter simple, Dr. Bakri has said about lot many things like, CBTs, the relaxation therapy. Now, average person, average, individual will have great difficulty in accessing all these lifestyle modification, interventions. So what I tell my patients, I can tell you that in first is the sleep. You have to regulate your sleep. You have to sleep at a constant time every day with a sleep hygiene in place. Not using mobile, not using laptops, not using television while you are attempting to sleep. And at the same time, so when you have a 7 to 8 hours of sleep every night, your migraine is going to get better. Definitely it is going to get better, right? Number 2 is hunger, hypoglycemia. Many patients get a trigger because of hypoglycemia because they don't eat for a long period of time. So a small snacking every 6 to 8 hours will help, right? That is very important. Number 3 is exercise. Exercise, you don't have to go to gym. You just walk, as Dr. Barki has said, you walk for about 20, 25 minutes every day for 5 days in a week. That will help. That will increase your blood circulation to the muscles, circulation to the brain, and that will make you fit. Besides other benefits, it will also help you in treating migraine, right? And also it will decrease and keep your weight in check. Obesity is a very important factor for chronification. So the patients must be caring for their weight. So exercise, number three. And number four is the stress management. Stress is the most important trigger for making the migraine headaches recurrent, right? Stress of various kinds, in the professional life, in the personal life, exams, some interviews, etc., right? So how do you manage the stress? Simple two things with the Indian patients can do is that they can learn yoga, do a yoga for at least 15 to 20 minutes in a day, or meditation for about 15 to 20 minutes a day. That these package, this four pronged pillar package for migraine treatment is going to actually help most of the patients of migraine, and then they can lead a normal, reasonably good quality of life, because it's a chronic disease. Migraine is going to be there for a long time.
Yes, a migraine is going to be there for a long time, and it impacts our daily life, day-to-day habits, whether it is going to school, college, or office. It really hampers our day-to-day flow and our productivity as well. So as we
We have
move ahead,
calculated, we have calculated the loss, the national loss due to migraine. In an economic paper, it is staggering 18,000 crores. India is losing, right? So if we don't become awake and engaged in migrant discussions, migrant awareness, then we will go nowhere. So it is very important to know about this.
I think so that this really plays an important role in creating impact and creating awareness and how we can aware specifically the patient. And as you mentioned that it how much of a national loss we occur. Moving on to the national perspective and the overall accessibility in the gaps which we have here, keeping in mind the interest of time, I would like to ask my next question, Dr. Shyam. So, what are the key healthcare delivery gaps which still exist in ensuring equitable migraine diagnosis and treatment across tier 2 and tier 3 and the rural regions? Because we can spread awareness till tier 1 or going on ground or spreading some awareness in tier 2 and tier 3, but still I think those of most of the areas are still left. So how can we cater that as well?
Yes, so those things, as already been mentioned, first the awareness about those things, and the awareness is that they think this is just the kind of the headache. So the awareness of the these things, this could be the beyond headache, it could be the migraine. And then the tie 2 tie 3, the what we see in the rural healthcare, the health seeking behavior, the health seeking behavior is also is what we see. It's a little bit people come late, and then already they try the over the counter drugs, and then the availability of the drugs, as sir told that there's some kind of what do you say, they have the medications which which are these are some kind of expensive medication which has come recently, and which are not much available in the rural area. That the even the among the neurologists, among the physicians, they have the kind of knowing that what is the I told you that the precision tailored medications, that is also they have the kind of they have little bit they don't understand, this is also important to understand that just as sir mentioned about that there's a uh, four pillars of the medication, for four pillar of the treatments. It's just not that we have to understand that just the giving the NSAIDs, giving the triptan is the only treatments. So these under recognitions, the delayed diagnosis, the shortage of trained specialists, gaps in the access to the evidence-based therapies, as I mentioned in the previous question, that precision-based medicine is also important depending on the trigger, the comorbidities, and definitely awareness is important. And then we have to face challenge the continuity of cares, where the migraine ongoing assessments. It's just not that we have to give one-time treatment. And now, because of the telemedications, consultation, electronic headache diaries also available. So wearable technologies are there. Mobile health applications also there. This will definitely help. This is by strengthening the migraine education, training the primary care physicians, developing the standardized evidence-based diagnostic and treatment pathway, expanding access to the affordable preventive and acute migraine therapies. I told you there's in the tier 2, tier 3 also need to be understand, and increase public awareness to promote early diagnosis, reduce the stigma. As I told, it's not psychological problems. It's a problem with some chemicals, and all those things need to understand. And then definitely regional headache referral networks, teleneurology services, integrate the digital health solution to facilitate monitoring, the follow-up, patient engagement. All those things are definitely important for the effect ability of as I thought, ability of effective medications. And this is a comprehensive healthcare delivery strategy. We can, with the workforce training, improving access to the diagnostic and therapies, patient education, digital innovations, and stronger referral system will definitely improve the better medical management in the tier 2, tier 3 cities and the rural areas. Yeah.
Definitely. So it will help us to reach there and to create that awareness and have a trained specialist who can cater that part of our country as well. To moving ahead, sir, to Dr. Mukul. So we discussed that how migraine impacts on the productivity, mental health, and quality of life. And since the government is working on so many health issues, disease, they're making some guidelines related to HPV, related to fertility issues or some obesity and diabetes. I think there should be some framework for the migraine as well. So should it receive a stronger recognition within the national public health and non-communicable disease framework as well? What is your view on this, sir?
I totally agree with you. It definitely needs the government to step in and increase the awareness about this disorder. And so it's quite doable from the government's point of view, and only the government will actually be able to do it. As uh, individual health care people and neurologists, there is a dearth of neurologists in India. I think there
Yes.
is the one neurologist to a million, or maybe two neurologists to a million population in India, and therefore it's going to be almost impossible to for us to reach out to the masses. And this is such a common disorder. We've already discussed that Dr. Debashish has done a survey, and he has found out to be around 25%, one out of four people walking in India have migraine. So how can we do that without the government support? And definitely we should raise this up to the government, and they should take more action for this. But while talking to you, one idea comes to mind, that with the advent of these YouTube and these small clips that come,
Reels and
if
shorts.
neurologists give these small shorts,
Yes.
1 minute thing, that this, if you have this is probably migraine, or a little bit about migraine, just short stuff which goes and becomes viral, then that's one other way of people learning about this illness.
Very rightly pointed out. So I think these are the video assets which are working quite fast, which is being impactable and relatable to the general audience as well. But as we also discussed, as something called sleep hygiene. So I think reels are the only thing which people are scrolling over the night and then sleeping, and I think that is also causing one of a trigger for the migraine. So I
True.
think every this is digital media. The new media is two-edged sword. So I think we have to use it quite judicially. I definitely agree to this point that that is one of the way which we can spread awareness through this. So thank you so much for this response, sir. My next question is to Dr. Satish. So, if you could advocate for one transformative policy or healthcare initiative to improve migraine awareness and access to specialized care in India, what would it be, sir?
Yeah, we have various, as Mukul sir said, Debashish sir said, it's a massive health problem affecting millions of people. So, with very few specialists around, reaching for the masses would be very difficult. So, how do we go about it as a nation? we can make a national migraine registry, national migraine program, where you integrate it into the healthcare system and help the primary care givers at PSC level, the community health workers. You give them small tools, easy tools to identify what are the symptoms, what are the of migraine, how do you rule out the secondary headaches, and then maybe Madlana, you make them empower them to initiate a first line treatment. Then you can I being in army, so we have a very robust system of referral. So we have a mechanism right from a person who's sitting at 25,000, 24,000 feet height at Siachen. From there, how does it transform the information or this to even up to Delhi? Okay, so you need to have a robust referral system. So the primary caregiver, Maulana, he need to treat simple cases. He need to identify complex cases or difficult cases, and then he need to refer. So the burden on the specialist would be going down. So good referral system. Then you need to increase the number of people who can treat this migraine. It's not a very difficult thing to do. So you need to train your medical professionals right from the undergraduate days, and you may have small capsule programs, CME programs, where you can train people to treat these simple. It's a very simple ailment, but then it becomes complex or difficult when it is neglected. So right from the beginning, it would be very simple. So then today's world you can access the digital this thing. You can use smartphones. You have teleneurology, as Jaiswal sir said. You can connect people from periphery to the this thing to help identify and treat patients. Public awareness programs, health education programs can be incorporated in this program. So all in all, awareness and availability of information and availability of maybe simple medicines. All the medicines again in peripheral, rural, peripheral PSCs, you don't get even simple medicine. I think we should make all available all the medicines and collect data, and maybe which will help the government to cater for budgeting for all those things. That's why maybe I would like that as a transformation.
Thank you, sir. Thank you so much. I think those ideas, these points will definitely help us to create awareness to make migraine care accessible as much as possible. And I think there are some ways which we can work in our system to make it more reachable. So, with this, I would like to thank all my esteemed panelists for sharing your valuable insights and helping us better understand one of the most misunderstood neurological disorder. And I'm sure that this discussion has reinforced an important message that migraine is not just a headache. It is a complex neurological condition, as Dr. Debashish has been reinforcing again and again in my every question, that this deserves timely diagnosis, evidence based treatment, and a greater public awareness, for which we are here and we are trying to create as much as awareness we can. And we hope that the session has encouraged patients, caregivers, and healthcare professionals to move beyond assumptions, recognize symptoms early, and seek expert care and support for better and long term access outcomes. On behalf of Voice of Healthcare and Amneal Healthcare, I sincerely thank all my distinguished experts for joining us and sharing your invaluable perspectives with us. Thank you so much, sir. Thank you to all, and thank you so much to our audience for joining us. I would just like to say that stay informed, stay healthy, and have a wonderful evening ahead. Thank you, everyone.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you.
Yeah.